the EGFR mutation, and there's another one still also treated with a pill. So now we have to break down cancers. It's not one thing. People who think there's a magic bullet out there are crazy. We're looking at a different disease, many, many, many different diseases, and we have to get treatments for each of them. Next slide. It's just how this works. You don't need to know that one. One more. It's just how this particular molecule works. Here's the other one I was going to talk about. About half of melanoma has been a nightmare. Malignant melanoma, it's a skin cancer. We've had nothing for it for forever. Turns out half the patients have a mutation in the growth factor called BRAF. And you give them a treatment, next line, called verapamil. It's an inhibitor of this particular mutation, and the patients will live longer. Turns out they don't live very much longer, but they get very good remissions. I had a patient on death's door, and I gave him this pill. It's again a pill. And he walked out of the hospital and lived another 6 months, and then it came back. Why doesn't it work longer? The answer is the cells are very smart. If they can't use one growth pathway, they'll use another growth pathway. And now what we're doing is developing inhibitors of not just one, but 2 and 3 growth factor pathways at the same time. You're going to see great progress in the next few years inhibiting these growth pathways. Next slide. Go ahead, one more. Okay, everybody wants to use the immune system to treat cancer. Wouldn't it be great if we could turn on our immune system and it'll attack the cancer cells? We don't have to use chemotherapy, and it'll kill all the cancer cells, and wouldn't that be great? Well, why can't we? First of all, it's very difficult because cancers, unlike, say, AIDS, which is a virus, cancers are our cells, our own cells gone a little wacky. But you can use the immune system for some things. The problem with the immune system is when it sees a antigen, when it sees a target on a cancer cell, it becomes a big population of immune cells, but it immediately turns itself off. The immune system is designed so it builds a certain number of immune cells and then stops, because otherwise the immune system would kill everything. The problem is you don't want it to stop. So ipilimumab blocks that turn-off mechanism and is now being used for a malignant melanoma. So it's one way to attack the immune system, to let it attack the cancer cells. Next slide. Next slide. One more. It's not a huge improvement, but there are like twice as many people alive at 3 years who would other be alive. Tumors are very clever. Not only does the immune system turn itself off, but the cells have a protective shell, the cancer cells, that prevent the immune system from attacking it. It's something called PD-L1. There are now antibodies to PD-L1 which will turn that off so the immune system can attack the cells. This is probably the hottest area today in oncology research, and we'll hear more about it. The end of this month is the American Society of Clinical Oncology meeting. We'll hear more about this. But this allows the immune system to attack cancer cells. Next slide. So, we've got antibodies that are attacking cells, and we made them cleverer. We have specific gene therapies for a handful of cancers, and we made them cleverer. We have growth factor targets, and there are more and more of them coming down the road. And finally, we have been able to start to adapt the immune system to kill cancer cells.
How about infrared?
And there are a lot of things out there, but the problem is you really have to do very careful studies. It takes, I'm dying. I have patients with prostate cancer who failed everything and are dying. There is a drug called cabazitaxel, which will be available sometime, which looks very promising in prostate cancer. It takes the FDA, once the drug is identified, goes through early studies, it takes a year or more for the studies to be done that are convincing enough that the FDA will approve the drug. And I can't get it for my patients. So, there's a number in lymphomas. There are 2 or 3 great drugs in lymphoma. They're not ready. The FDA still hasn't approved them. They want to make sure they're safe. They want to make sure they're effective. But when you talk about something like infrared, it's not enough. You have to show me a good, controlled, carefully done trial. Because everybody and their brother thinks they know how to take care of cancer. Trust me, it ain't that easy. And we really have to be very careful about claims that are made without any data, nutritional claims, heat claims, infrared claims, no data. I don't mind people, when I have some Asian patients, they will come in with enough medicines to cover this table because they're trying every alternative medicine known to man. I have some problems with some of them because some of them get in the way and can make trouble with your metabolism. I've had a couple of patients who had liver problems because of some of these drugs. But by and large, I don't care what they use. And I'll be happy, if you scrape down this wall, ran a series of tests and showed me it worked better than something else, I would scrape down the wall, or every wall. You gotta show me data. You gotta prove to me that something works. I go back a long way. When I started doing oncology in 1974, there was a lot of stuff about one thing or another working. When good trials are done, most of that stuff falls away. It's very hard to do this work, it's very time consuming. The bottom line is we know where we're going, we are making progress today. I see patients in my office all the time. I have 2 patients with lung cancer, 7 years with metastatic lung cancer. Never saw that in the past. The pancreatic cancers, never saw that. Lymphomas with all kinds of new medications, never saw it in the past. So we're making progress. It's very exciting to be an oncologist, and hopefully we'll all live long enough to see this disease finally
Is it done
gone.
usually on human beings or